Dr. Tanmay Gupta for his talk on obstacles in refractive cataract surgeries.
Hello. Good afternoon, everyone. I'll be quick. So I'll be talking about the routine obstacles that we face in performing a refractive cataract surgery, which is the need of the hour. Yeah, the slide is not moving. Huh. So with the help of sophisticated equipment and technologies, technologies that encompass our newer understandings of ocular anatomy, physiology, and pathology, desired refractive outcomes look achievable. The key to overcoming the obstacles in a summary is counseling, counseling, and counseling. So the challenges that we routinely face, like IL power calculation, can be managed by a staged approach, which can improve the patient's quantity and quality of vision. So choosing the correct IL formula is the first challenge, primary challenge. So the Barrett Universal 2 has given us good results with 81% achieving intended refractive result. It takes into estimated lens position into account. Barrett's True K for calculates modified K in previous refractive surgery patients. Hagees or Hoffer Q for eggshell length less than 22. SRKT for eggshell length more than 26. And online calculators should be used along with the optical biometers or A scans immersions for a better predictability. Matching IOL with spherical aberration profile. So Dr. Uday Devgan gave a decision tree, which was introduced in the American Society of Cataract Refractive Surgery conference. So in case of a patient who has undergone a prior hyperopic LASIK, a traditional IOL with a positive spherical aberration should be implanted. In cases of patients with prior myopic LASIK, aspherical IOL with negative spherical aberration should be implanted. In patients with no prior refractive surgery history, with a likelihood of IOL decentration, aspheric IOL is zero spherical aberration, and where the IOL is not likely to decenter, and if the depth of focus is critical, aspheric IOL is zero, neutral, and if the image quality is critical to the patient, like active males or active females who are driving regularly, aspheric IOLs with a negative spherical aberration. So deciding on the toricity or the non-toricity of the IOL, if the delta TK is 0.75 to 1, it suggests the toric IOL implantation. In case of any ambiguity that you face on a day-to-day practice, Barrett's online toric calculator, along with the consideration of the incision site and the SIA, gives near accurate prediction of toricity. If using a presbyopic or an accommodative IOL, even a 0.5 diopter of astigmatism should be considered for a toric IOL. Eligibility of a presbyopic correcting IOL. An ideal candidate is someone who has a low hyperopia of 1 to 3 diopters, no ocular or macular disease, less than 0.75 diopter of astigmatism, and target refraction that is within the range of correction of the chosen IOL. When to avoid previous refractive surgeries, patients with previous refractive surgery, patients who are frequent night drivers because they complain with dysphotopsias, halos, tear film deficiency, corneal disease, and macular diseases. Coming to the second challenges, that is corneal irregularities. To contain the corneal irregularity for a good emmetropia, the concept of total corneal power comes here. So most IOL calculations rely on surface keratometry measurements. In an eye with an irregular cornea, the posterior corneal surface may not exhibit the classic -6 diopter. So using the central 4.5 millimeter of total corneal power as measured by Scheimpflug or TK cone by optical biometers has resulted in good outcomes. If decentralized ectasia is seen, then corneal collagen cross-linking using the Athens protocol, which is topo-guided PRK plus C3R, can be done. Prior refractive surgery, detailed corneal imaging is required to identify prior refractive surgery ablation profile, the treatment patterns, the high order aberration profile, for identification of corneal curvature regularities that may preclude the use of certain IOLs, to assess for the further laser vision correction candidacy, if necessary, to achieve the planned refractive target postoperatively. Surgical precisions that can be altered, that should be altered, like scleral tunnel approach in prior RKIs, knowing your SIA, the site and depth of the incision, MICS phaco, and the best will be a femtolaser laser assisted cataract surgery with limb relaxing incisions. Patient expectations. So cataract and early questionnaire by Dr. Dell gives us an insight to the patient expectations. It helps select the right IOL for the right patient. Don't oversell the IOL. You're not the IOL manufacturer. Explain both pros and cons and explain the possibility of a refractive surprise. The myopic eyes comes with their own set of problems like the greater risk of cataract, long-term stability issues due to greater decentration issues, and multifocals are not really indicated because it decreases contrast sensitivity. So the solution is accurate biometrics, Barrett-Truke formula with central 4 millimeter zone in prior refractive surgery patients, plate haptic IOs are much preferred in high myopic patients, and monofocals or read-offs. The limitations of the biometry can be seen in dense media, post-glaucoma surgery, anisometropia, amblyopia, poor fixation, and very short or long eyes. So ocular surface disease is an underestimated problem. Adequate diagnosis and preparation of the ocular surface before biometric measurements can reduce the rate of refractive surprises after surgery. Treatment is expected to primarily reduce inflammation, stabilize the tear film, and alleviate symptoms prior to the ophthalmic surgery. Thank you.